Good morning, everyone. My name is Camilo Gonzalez Velasquez, co-host of the Thyroid by MD's webinar series. I want to welcome all of you and introduce our esteemed speakers for today. First, we have Dr. Daniel Kwon, an associate professor of otolaryngology at the Keck School of Medicine in the University of Southern California. Dr. Kwon trained in head and neck cancer and specialized in robotic and microvascular surgery. His clinical focus includes thyroid and parathyroid surgery, oral cancers, and flap microvascular reconstruction. Dr. Kwon is currently the co-director of the USC Thyroid Center and plays a pivotal role in leading the thyroid cancer program at the Children's Hospital of Los Angeles. Joining him is Dr. Franklin Tessler, Emeritus Professor of Radiology at the University of Alabama at Birmingham. Dr. Tessler currently serves as the Senior Medical Officer for Health System Information Services at UAB Medicine. With over 70 peer-reviewed publications and more than 170 oral presentations worldwide, Dr. Tessler's contributions to thyroid ultrasound are internationally renowned. He notably chaired the committee that developed the Thyroid ACR system in 2017, a critical system for risk stratification and management of thyroid nodules globally. And currently, he leads a global effort to harmonize the recommendations for management of thyroid nodules based on ultrasound, which is a topic we all eagerly anticipating and want to learn more about. I want to thank both of you for carving out some time this morning to discuss this current publication and share your expertise with the audience. And before we begin, I want to encourage all of our listeners to send in questions, which we will try to address and discuss towards the end of the hour. So with nothing to add, Dr. Kwon, the mic's all yours.
Well, thank you. Thank you for inviting me to share my our project, our recently published review and meta-analysis. In our study, we sought to sort of define and further characterize thyroid nodules that are not well categorized by the American Thyroid Association 2015 guidelines, where they include a ultrasound risk stratification system. This study was recently published in Thyroid this past year, and thanks to all my co-authors as well. And so, just to be clear, this is really coming from, or this presentation at least is coming from a surgeon's perspective, where we're more worried about the sort of clinical ramifications. Maybe later in the discussions, Dr. Tessler can talk to us more about the radiology side of things. I have no relevant disclosures. And so, of course, all of us here, many of the audience probably are well aware, I've seen some of these slides before. Over the past several decades, thyroid nodular disease, thyroid cancers have seen a really rapid and large increase. Thyroid cancers, the fastest growing cancer in both men and women. And we see this large rise in the incidence of thyroid cancers. But generally speaking, clinical outcomes, mortality have remained very excellent for this disease. And so, much of this is attributed to the increase in imaging modalities used. This is especially important considering a lot of the estimates place detectable thyroid nodules in the 50 to 60% range for the general population. And so, of course, this has been subsequently followed by significant increases in, diagnostic studies, biopsies, and of course, thyroid surgeries. This has been well documented over the years. From a surgery perspective, this is one thing we focus on is the fact that so much of thyroid intervention, thyroid surgery is being done by really, low volume or occasional thyroid surgeons. This, of course, leads to increased cost complications, and this has been well studied in our field. And, putting it together, there's been a real concern and sort of a pendulum backswing away from kind of over-treatment, over-diagnosis, and more focusing on harm reduction for the individual, as well as for the population when it comes to thyroid nodular disease. And, this is really kind of based on the tenets that, even though thyroid nodules are so, common in the general population, the vast majority of these nodules are benign. Despite that, just because of detection and workup, a lot of indeterminate or benign nodular disease is being operated on. And even, cancers, there's a significant subset of low risk or, very early thyroid cancers that, it's now well established that remain quite stable over time and could possibly remain subclinical if not discovered early. And so what we see over recent years is a sort of transition into kind of risk stratification, patient selection, what we might call precision medicine. And so we see algorithms that are a lot more sophisticated that try to parse out, which are the nodules we don't really need to worry about and which ones that we do. Of course, thyroid ultrasound is really the mainstay first-line diagnostic study for thyroid nodular disease, and it's been very well studied at this point. Certain ultrasound characteristics have important clinical implications, and so these characteristics have been used for a variety of risk stratification and classification systems. The American College of Radiology TI-RAD system that, of course, Dr. Tessler has been instrumental in. Other countries, other regions, other societies all have different versions of this, and of course, we have the American Thyroid Association as well. Now, a lot of these classification systems are a point-based system, and so this is, from the white paper from the TI-RAD system, and you see Dr. Tessler's name on there. You also see Dr. Ed Grant on there, who is really one of the main figures of thyroid and neck radiology here at USC. And so this is probably the most widely used classification system. It's point-based with recommendations based on the 5-tiered point system. This, along with the other, classification systems, have all been shown to be quite effective in helping better accurately describe nodules and their behavior, prevent unnecessary biopsies. In this study that was done right around the time as the TI-RADs were released, I believe in 2017. And so, looking at experienced radiologists, looking at thyroid nodules, those that were, giving out diagnoses based on personal expert opinion versus a, formalized system, we see that, the distribution of diagnoses are much more even. And in this study, it was found to prevent unnecessary biopsy in a significant portion. Now, the American Thyroid Association, while this is probably not quite as well used, the guidelines in general are by far the most referenced and followed guidelines worldwide. Within the 2015 guidelines, a ultrasound risk stratification system was also included. And this is more of a pattern-based system. It's looking largely at the same characteristics as many of the other classification systems. But instead of a point-based system, it's a descriptive pattern-based system, essentially combining the composition or echogenicity of these nodules along with the presence or absence of high-risk features such as irregular margins, punctate echogenic foci or microcalcifications, hollow rather than wide, etc. And within the text of the guideline, this discusses that these kind of categorization should represent the vast majority of thyroid nodules that we run into. However, since the publication of these guidelines, several studies have recognized there are a subset of thyroid nodules that don't quite fit well into these categories. And essentially, these are nodules with a lower risk composition, so mixed isoechoic, hyperechoic nodules that also have some of these high risk features. And so in this photo, again, I'm not a radiologist, but in panel A, I think you can see a hyperechoic nodule. You see the calipers on there. A hyperechoic nodule, perhaps taller rather than wide, perhaps some microcalcifications in there. In panel B, you have this, partially cystic but partially solid nodule, again with some possible calcifications. And then in the third panel, you see a mixed nodule again with perhaps some echogenic foci, although I'm sure different radiologists would look at this and perhaps describe it differently. So in our study, which was actually conceived by Trevor, Dr. Angel, who is kind of the senior co-author in this study, was to say, okay, studies are mentioning this type of nodule. What's the true incidence of these nodules? Are these just rare things that we don't really run into too often? And what's of course, most importantly, the risk of malignancy in these what we deemed ATA nodules. We spent a lot of time trying to decide what to call them, because different studies have called them undefined, non-classifiable, unclassified. We just decided on this acronym NCATA. And of course, sort of by defining these characteristics, this would be a basis for further management and recommendations. So this study was registered in Prospero. We followed the PRISMA guidelines, et cetera, et cetera. Our literature search was on PubMed and Embase. Of course, it was IRB exempt. We ran our literature search from January 2015. This well preceded the release of the ATA guidelines, the latest edition, and ran till August 2022. The population that we were interested in were adult thyroid nodules greater than 1 centimeter. Of course, the use of the American Thyroid Association ultrasound system, and then nodules where we definitely knew the pathologic diagnoses. We excluded, studies looking at subpopulations, for example, only medullary thyroid cancers, or only looking at indeterminate nodules, only looking at nodules in patients with Hashimoto's, etc. And of course, studies that did not include or mention NCATA nodules. You can see our PRISMA workflow here on the right side of the screen. We identified over 8,000 abstracts and titles. After kind of taking out the duplicates, we screened over 6,000. These were screened by 2 authors independently. Any discrepancies or any scores that were unclear were resolved by the senior authors. After that initial screening, we found 164 abstracts that we wanted to look into further. A lot of these were actually meeting abstracts and things like that. So we ended up doing 135 full text reviews. Again, these were independently reviewed by 2 separate authors, with kind of the final grouping and discrepancies were discussed by the senior authors, Dr. Angel and myself. And ultimately 16 studies were included for analysis. Notably, in our results, we actually have 17 studies listed. It's due to the fact that one of these studies had a prospective and retrospective arm that we sort of treated as 2 separate cohorts. Now, kind of on the bottom right, we can see some of the reasons that some of the manuscripts were excluded. And I'll talk about that a little bit here. A lot of times, when we start out with these reviews, you have sort of a cut and dry criteria. Seems pretty straightforward, but of course, when you delve into the actual data, things can be a little bit less clear. And so some of the dilemmas we came across were several of the studies included a mixed population, with sub-centimeter nodules being a part of the data that was reported. And so, how we faced this was obviously looking initially for nodules over 1 centimeter. Thankfully, many of the studies separately reported outcomes in their sub-centimeter population and their over 1 centimeter population, and in which case we used only the cohort of nodules above 1 centimeter. When it wasn't clear, then we oftentimes contacted the corresponding authors of these studies to try and get kind of subpopulation data. And finally, we sort of ended up arbitrarily setting this cutoff just to try to include the most relevant data possible, of 15% of sub-centimeter nodules within the overall cohort to be included. And this was kind of just a little bit arbitrary. This was a kind of a natural dividing line. We saw some studies, several studies that had, perhaps 8, 9, 10% subcentimeter nodules in their population that couldn't be parsed out, versus other studies that had really a large percentage, 30, 40%. We also kind of ran into the fact that, of course, you have to wonder in many of these studies that would have, perfectly fit our criteria, except for the fact that they never recognized NCATA nodules. Now, of course, this could be because they truly didn't have any NCATA nodules, or they sort of whenever they came across these types of nodules, just forced them into a category. This is something that was mentioned in a couple of our papers, where even in one paper they say, hey, we saw X number of these undefined nodules. Yet after kind of consensus with all our radiologists, we forced it into one category. In that paper, thankfully, they still reported on these nodules separately. And so we were able to use that data. But, that does make you wonder about the true incidence of these nodules. Finally, we did notice that studies did have different, definitions of what they would define as definitive diagnosis. Some studies simply had a cytology, diagnosis, and that was it. Other studies, required 2 negative biopsies until they called a nodule benign. Other studies had, a nodule had to be FNA benign plus, a year of follow-up, things like that. And, that does play some impact in which nodules were included, because, of course, many nodules that could not have a definitive diagnosis, some of these studies were excluded from analysis. When we looked at these studies, these were sort of the main primary data points that we were interested in. Of course, the incidence, the malignancy rate, but we also looked at a lot of the study characteristics, whether they were single institutional versus multi-institutional, prospective, retrospective, whether or not they included subcentimeter nodules, and geographically the location of these studies in these populations. As I mentioned, ultimately 16 studies were included with a total of a little over 21,000 nodules and 1,872 total NCATA nodules. So, ultimately quite a robust sample size. And you can see these characteristics. These were largely studies from Asia, and a small percentage coming from Europe. And really, this is kind of the meat of the study. So we found the incidence was about 8% in our random effects analysis, and the malignancy rate was just over 20%. You can see here on the plot on the right, there was quite a high level of heterogeneity, which we'll talk a little bit more about. Due to this heterogeneity, we did subgroup analysis based on the other study characteristics. These were the main factors that were included in our initial analysis. And really the ones that were most relevant were, study type, looking at multi-center versus single center. We found that, multi-centered studies had about half the rate of malignancy as single centers. And even though these were only, I think, 6 studies, the multi-center studies did show only a moderate level of heterogeneity, versus essentially all the other cohorts we looked at always had a high level of heterogeneity. Retrospective and prospective was also a significant contribution to heterogeneity, with prospective studies only having about 1/3 of the rate of malignancy compared to retrospective studies. But again, we see this high level of heterogeneity in both groups. Other factors such as, whether or not, definitive diagnosis was obtained by surgical only specimens versus surgery and FNA, whether or not there were subcentimeter nodules involved, where in the world these studies were done. All of these did not show any statistical significance in impacting heterogeneity, though the definitive diagnosis criteria, whether it was surgery versus surgery plus FNA plus clinical, did approach clinical relevance, with the surgery-only studies having a much higher rate of malignancy. We also performed a secondary meta-regression analysis. We looked at additional variables, sample size of NCATA nodules versus total nodules. We also looked at the rate of excluded nodules. As I mentioned, in many of these studies, a significant portion of nodules ultimately were left out due to not having a final diagnosis. We looked at percentage of histologic diagnoses, whether some of these studies were nearly all FNA based, some of them were only surgical only cohort, and exclusion of outliers. Now, full disclosure, we thankfully had a biostatistician helping us with this, and so any technical aspects of this are really way above my level of understanding. But on this meta regression, this showed that study type, in terms of multi-centered versus single center, prospective versus retrospective, were indeed significant contributors to heterogeneity and impacted rates of malignancy. And then in this meta-regression analysis, the percentage of surgical pathology did end up playing a significant role. And really, this is, again, looking at not just a dichotomy versus studies that were surgical only versus surgery plus FNA. This was also looking at studies that had a majority of patients or a large portion of patients who ended up having surgery versus those that didn't. So the takeaway conclusions were that NCATA nodules were relatively common, in our cohort, and had a risk of malignancy of about 20% overall. This would put this in the upper range of the intermediate suspicion of the ATA system. And of course, as I mentioned, these different study characteristics played a significant role in risk of malignancy. So when we sort of look at these factors, in our discussion, we sort of theorize or think about a lot of this. I think a lot of this is relatively straightforward, right? Why did these contribute? What could this mean? Of course, like any study, a multi-centered study, has a lower rate of, consider systemic error than a single center study. So that, makes some sense. This would suggest that the multi-centered studies were perhaps a little bit closer to, what we would find in the real population. Prospective versus retrospective. This is a little interesting, obviously, I think all of us have probably come across this a scenario where we see something strange a few times in a row and we're like, huh, that's really funny, let's do a study on it, let's look back at our at our experience. And so it's a little bit of a self-fulfilling prophecy, which could you could say that it increases it would tend to increase the rate of malignancy or incidence in a retrospective study. On the other hand, for something like this, which is not a categorized nodule, you could think a prospective study where radiologists are, are aware of NCATA nodules, are acknowledging them. You're a little bit more likely to press that button if you were having some sort of prospective study. So these are some of the thoughts that we had. Finally, histologic diagnosis, it obviously makes a lot of sense. Patients with these types of nodules, we're not capturing other clinical characteristics, other risk factors. So patients being selected for surgery, obviously would potentially have higher risk for malignancy due to other factors not well represented just by ultrasound characteristics. And in this plot, that didn't end up in the final paper. When we see the effect size, we can see that the studies that had a large portion of their cohort undergoing surgery tended to have a much heavier impact on the effect of this on heterogeneity. We did do a risk of bias analysis. We used a QUADIS-2 tool. This had been used in other diagnostic reviews, imaging reviews. This was again independently scored by two separate authors, with any discrepancies resolved by the senior authors. And I think ultimately, we have to accept that these are nodules that are being selected for, study, right? And so there's that kind of underlying bias that really impacts really all the studies. But some of the unclear risk or higher risk scores you see here are because a paper perhaps didn't confirm that the study cohort was recruited uh, chronologically, studies that didn't confirm whether or not radiologists were blinded and things like that. As far as limitations of our study, I think we really talk about a lot of it, throughout, explaining how we did our study. But of course, other things worth mentioning, we didn't, this largely predated NIFT-P for a lot of these studies, and they were never mentioned in any of them. Similarly, molecular testing wasn't used in any of our studies. And finally, as I mentioned before, significant number of studies excluded, relatively large portions of the cohort since final diagnosis was never made. We actually did a secondary analysis looking at only studies at indeterminate nodules, and we didn't find anything interesting to publish, unfortunately. So in conclusion, I think this study is important that it takes an entity that we had been seeing in the literature and better defined it. It supports that these are nodules that do come up and do have a significant risk profile. Such that FNA is likely warranted. Again, this approximates even on the low spectrum of our subcohorts a risk of malignancy in that intermediate range. And finally, recognizing better defining this study like this would hopefully allow other studies in the future, further guidelines to recognize these types of nodules and provide further clarity. Thank you.
Thank you, Dr. Kwon, for your incredible presentation, and congratulations on this amazing work. We're going to go forward with Dr. Tessler's presentation right now. We're going to go back to Q&A from the audience at the end. Dr. Tessler.
Thank you and good morning. I appreciate the opportunity this morning to comment on this important study, giving my perspective. These are my disclosures. Normally, when discussing a study like this, I might comment on the methodology and some of the limitations, but I really have nothing further to say about this study other than great work. Thank you. I think this is wonderful stuff. And what I'd like to concentrate on in the next 10 minutes or so is what do we do with this information? There are two approaches that one could take. First is to use another method to classify nodules other than the pattern-based system used by the ATA. And the other possibility would be to revise the ATA guidelines to not exclude any nodules. Let's look at both of these. Starting off with another classification method. Indeed, this is what we did with ACR TIRADS when it was published in 2017. It has 5 feature categories with a total of 18 descriptors, descriptors being another term for ultrasound features. And our somewhat informal motto as we were developing this was no nodule left behind. That is, we wanted to make sure that every nodule would be classifiable regardless of its malignancy risk. And because of the point-based system, we were able to accomplish that. The other possibility would be to revise and possibly add to the ATA patterns. These are the patterns as they exist in the current system, which was published in 2015, 2016, and this is well known to people who use this system. A bit about using points or patterns to describe and classify thyroid nodules. Much has been written and said about this over the years, and I want to just give a little bit of an additional perspective on that. Starting off with patterns on the left. Patterns allows you to take what I call a holistic approach to nodules because each pattern may have a unique risk of malignancy. Now that advantage is reduced somewhat because these are grouped into malignancy risk ranges, but it's certainly worth considering as an advantage of the pattern approach. And when I talked to some colleagues who use the ATA system as we were developing ACR TIRADS, their outlook was that patterns are easier for people to discern than individual features. The points-based system, which is also used by the Chinese TIRADS, which was published several years ago, in this system, the features are independent from one another. Therefore, you have to ask the question, what if a descriptor's contribution to risk of malignancy depends on the presence or absence of other features? So that's a drawback of this approach. It's also worth pointing out, and I've mentioned this in previous discussions at Thank Foundation conferences like this, that really the ATA system and ACR TIRADS are more concordant than one would think. That is, there are more similarities than differences. So for example, in these 7 patterns, the 2 systems are fully concordant, including in the threshold of size used for recommending FNA. In these additional ones, the difference is only a ½ centimeter in the threshold. Here, as you get into the lower risk categories, the threshold for FNA differs by a greater amount, but still only 1 centimeter. And here are ones that also differ because in the ACR TIRADS, none of these 3 patterns are recommended for biopsy, whereas they may be considered for biopsy if the diameter is greater than or equal to 2 centimeters in the ATA guidelines. But my overall message on this slide is really to say that there is more similarity than meets the eye. In trying to decide how many additional patterns we may need to add to the ATA guidelines to encompass every nodule that's classifiable by ACR TIRADS, here's one approach to thinking about that. And that is to look at how many different combinations of features there are. Here is a portion of the ACR TIRADS chart that I showed you before. 5 feature categories: composition, echogenicity, shape, margin, and echogenic foci. And in the first 4 categories, the observer has to choose the one feature that is present. Echogenic foci is different because these are not mutually exclusive and more than one can be present in a given nodule. If you take of all these different features independently and try to figure out how many combinations there are, that would be one approach, but that really doesn't work, because in fact, as I just showed, these are grouped and some of these features are mutually exclusive. So here's one combination: mixed cystic and solid, anechoic, taller than wide, lobulated or irregular, and say macrocalcifications. That's one combination. Here's another, emphasizing the point that in the final category, you can have several of the features present in a given nodule. In reality, mathematically, there are almost 2,000 combinations of features, but the truth is that most of them can never occur in practice. So one approach to revising the ATA guidelines would be to use the data from the existing analyses to add the most significant patterns, that is, the ones with the highest risk of malignancy. And that's where a study like the one that you just heard about from Dr. Kwon can be really helpful. I will also mention that the ATA guidelines are currently being revised, and I'm told that the people doing this are nearing the end of that work and that we should expect to see the revision sometime in 2024. I've not seen specifically what they've changed since 2015. So I'd like to continue by talking about where do we go next? What do we do with all this? Well, if you go between 2005 and 2021, when the last set of guidelines were changed, that is K-TIRADS, there are at least 12 different systems in use worldwide, and no fewer than 7 of these are called TIRADs. That is something that leads to confusion. And in order to gauge that, several years ago, Jenny Hong and several of my other colleagues and I decided to conduct an international survey on utilization of 5 different risk stratification systems. And this was published in Thyroid in 2022. And importantly, most of the respondents agreed or strongly agreed that risk stratification systems are useful to guide management of thyroid nodules. And I mentioned that because we were wondering if some people, particularly those with a lot of experience and expertise, might not want to use a risk stratification system because they felt that they, based on their experience, could do just as well. One of the other questions we asked is which ultrasound risk stratification systems are used in your practice, and asked them to check all that apply. And you can see of the systems we looked at, it was all over the place. And some practices used more than one, sometimes even 3 different systems, depending on the practitioner. We also asked about what could be done to improve agreement, because one of the big issues with all the risk stratification systems, including ACR TIRADs and the ATA guidelines, is that they are all based on the same ultrasound features or descriptors. It's not as if anybody has come up with some new ultrasound sign over the past 10 or 15 years that nobody else had found previously. And one of the things we found is that there was a lot of support for a universal lexicon, a lexicon being a set of definitions of ultrasound features. And we also found a lot of support for that being accompanied by an ultrasound atlas showing what these features are. I'll talk more about that in a second. But the point here is that whenever a risk stratification system is published, typically it's accompanied by some examples of the features on which it's based, but those examples that are provided are necessarily limited. Even if there are online supplements, there just aren't enough of them to really provide enough examples to show everybody who uses that system what constitutes a given feature. This leads to several problems. It's confusing for practitioners and patients, and I'm here referring to the fact that there are multiple different systems that sometimes have different results, different management recommendations for a given nodule. Keeping up with updating these systems worldwide is a lot of work, so there's a lot of duplication of effort, and it's difficult to compare the results of studies that are done doing different systems. And you heard a little bit about this a bit earlier. Since 2018, I've led an international project that is managed by a steering committee. The people working on this, we collectively call ourselves the International Thyroid Ultrasound Working Group. And the steering committee represents the professional organizations that have developed or published risk stratification systems or guidelines, either alone or collaboratively. And you see those systems and guidelines represented here. We've been working on this for 5.5 years. Now, I've been asked many times why it took so long, and part of it was trying to get consensus among people around the world. Just scheduling online meetings was challenging, and of course we had a small thing called the COVID-19 pandemic in the way, and that slowed us down a bit. But I'm pleased to say that phase 1 of our effort, which is to develop an international universal lexicon, was published a few weeks ago in Radiology, and this is from the title page. And you can see here there are the lead author was Cosimo Durante from Italy, but there are multidisciplinary participants from around the world, including endocrinologists and endocrine surgeons. The other thing I'll mention that I think is really important and is very heartening for me is that many of the people that you see listed here as co-authors are or have been involved in developing the guidelines produced by their respective professional societies. I am confident, and I know this from talking to all these people, that they wouldn't be continuing to participate in this international project if they didn't think it was worthwhile. So there is a lot of continued enthusiasm from this group as we continue with what we're going to do next that I'll mention in a moment. And these are just two figures from the lexicon. I encourage you to look at this paper. It was available freely for the first 2 weeks after publication, but it should be easily available at most academic institutions that subscribe to radiology, which is a leading imaging journal. And this shows we call the system iThyroid, so that's the terminology used in the paper. And here, on the left, you see in the composition category the 5 different descriptors, each of which has one illustrative sonogram and a word definition with the risk of malignancy associated with that feature, where we could come up with one based on the literature. Here on the right is an example of another feature which we ended up calling direction of growth. That's familiar to people who do thyroid ultrasound as taller than wide or wider than tall, and we adopted this alternate terminology. But this is just to show you what the lexicon as presented in this paper looks like. But as I mentioned a few moments ago, just showing these few images with their word descriptions is not going to be enough. So what we are planning and putting together now is an online atlas. I'm still working on where this is going to be hosted, but I'm confident that's going to be taken care of fairly soon. And that's going to include 4 things. First of all, it's going to include examples of still images or static images of pathologically proven nodules. We're also going to include video clips, because again, those of you who do thyroid ultrasound know that when you're scanning a nodule, what you see on the screen is much better represented by a video clip than it is by a static image. And we also plan to include drawings to highlight different features of nodules. And importantly, we also plan to add what I call mimics. So for example, if you take a feature like microcalcifications or punctate echogenic foci, as we call them in ACR thyroids, there are a lot of things that look like that aren't. So in addition to showing people examples of punctate echogenic foci, we are also going to show examples of things that look like punctate echogenic foci but aren't. And we are currently gathering images and clips to use for this. Here are our next steps. The first thing, which we are currently putting together, is a study to validate the lexicon. It's not enough to just come up with a lexicon with some examples. We want to know if it makes a difference in addressing the primary problem that plagues all the risk stratification systems. That is reducing inter-observer variability in assignment of ultrasound features. We're putting together this study, as I just mentioned. It's going to be based on video clips rather than static images. And just at a high level, the way we plan to do it is to have observers look at proven nodules and say what features are present, both before and then after a period of time, after they've had a chance to look at the lexicon and its atlas. The next step after that will be to use this lexicon to serve as a basis for a new risk stratification system that we're tentatively calling iThyroids for international thyroids. Of course, that's going to be a heavy lift. That's a somewhat aspirational goal, but I'm very encouraged by what we've done so far that we're going to actually be able to accomplish this. And if we can, I think this will be a large contribution to the field of thyroid nodule management. With that, I'd like to thank you for your attention this morning, and I'm sure we're both open for any questions that you may have. Thank you.
Thank you, Dr. Tessler, for your presentation. I think I had many questions jotted down on what to do when you have a non-classifiable by the ATA nodule. And I think some of the questions you answered during your talk. And I'm going to have to go with my first question, Dr. Kwon. So what do you do? You have do you use ATA as your primary classification system? If so, if you have a non-classifiable nodule, do you use an alternative classification system, or do you do something different to make a decision? Because you spoke about real life, and how some of the studies that were included in your study had to be excluded based on biases, and how people have forced these non-classifiable nodules into a category, which in the end of the day we do in the day-to-day in practice now.
In my personal practice, the large majority of patients have a formal ultrasound done by a radiologist. Like I mentioned, we have Dr. Ed Grant at our institution. Him and his colleagues really help us out. And so I don't run into this personally very often. Of course, I think one of the benefits of the ATA system is, I think for non-radiologists, it's a lot perhaps simpler to sort of at least think about. And so I think really all of us who look at ultrasounds in our clinic, where we don't have a nice kind of clean cut score from a trusted source. I think probably all of us have the experience currently with sort of the corporatization of radiology. We get lots of these outside HMO kind of based studies, and where sure, we get a report, but the quality of the report varies significantly. And so, that's where we sort of use the ATA system, at least intuitively, looking at these nodules. I can't say I've ever actually seen one personally. And so this was more academic for me. But I think it's quite possible that I could have run into one that would have fit into this category, but I didn't have the required expertise to even recognize it. I think, in our cases, we sort of have the luxury of, just calling up one of our colleagues and asking him to take a look at a scan if we're not sure. And so, personal experience, very limited for me personally.
If I could just comment on that as well. I don't come across this in practice either, because of course I use ACR TIRADS. But if I was asked to evaluate a nodule based on the ATA guidelines and didn't fit into any of the patterns, there are two approaches. One of which is you could sometimes bend things a little bit to sort of, it doesn't quite fit into pattern X, but it's close enough that you can make it fit. And the other is you can just apply another system like ACR TIRADS to it. That's widely available, and you know that the nodule is always going to be classifiable that way. I don't know if how this is being addressed in the upcoming revision to the ATA guidelines. I suspect it will be in one way or another, although I can't tell you how that's going to work.
Right. That's very interesting. Whenever I speak about the differences between the ATA and thyroid ACR to my fellows, I tell them, like, it's a natural system. It's a natural process for everybody to do pattern recognition. Like, if you look at a tree and it has oranges, it's an orange tree. That's like kind of what you do. You don't classify it. You don't do different characteristics to see if it's an orange tree. That's what we do as humans. However, the experience has taught is that risk of malignancy is not a black or white kind of thing. You don't look at it and say it has this risk of malignancy. So I was kind of hoping this question would have come up earlier. Dr. Chen from Mount Sinai asked, what is the role or the value of using artificial intelligence, which kind of at the end of the day uses pattern recognition. So what are both of your thoughts on artificial intelligence and how we will incorporate this in the future?
Well, I'll be happy to start with that. I co-authored an article in Thyroid that was published earlier this year on the future of artificial intelligence in thyroidology, specifically nodules. So the answer to that is AI is going to have a huge effect. There are several commercial systems that are available that are FDA approved in the US that are can be used right now, and they apply different machine learning and AI techniques to classifying thyroid nodules. For example, one of them will, I'm going to say, look at the nodule. That may be a little anthropomorphic, but will pre-populate. It's based on ACR TIRADS and pre-populates the screen with the features that it deems to be present in the nodule. But it also has a modification that it optionally applies to the level risk level of the nodule that may upgrade it or downgrade it based on its analysis. I am convinced that AI techniques like that one are going to have a huge impact for a number of reasons. One is they've already been shown in the literature to reduce the time it takes to classify a nodule, and that, I think, by alone is a benefit. And they also have been shown to be more accurate than human observers, at least, especially those with lesser experience. So I think we're going to see, just like we are in many other areas of in medicine and outside medicine, AI, I don't know if it's going to take over what we do, but it's going to have a huge effect over the next few years. And this is something I get asked to talk about since I wrote that article. I'm getting asked to talk about this all the time, so I know there's a lot of interest in the thyroid world about this topic.
Yeah, and just to echo that, I think we've been hearing about AI for really a long time, but it's not until these past few years where we have these machine learning type AI tools. We're just publishing one, not related to thyroid ultrasound or thyroids at all, on oropharyngeal cancer, where I think anyone who's done any sort of dive into recent AI would tell you that it's very impressive. In our study, we were looking at, could AI, specifically ChatGPT, give patients accurate information, personalized information on their, throat cancers. And, while of course we were able to criticize it, we compared it to expert opinion and guidelines, and of course it's not perfect. But I think all of us reviewers who looked at some of these responses were really impressed with the results. I think, and so I agree. I think this is definitely going to be part of our field to a great extent in the coming years. To what what it means, I think it's pretty unclear. I'm just thankful to be a surgeon.
Couple other things too. Yeah, I know what you mean. Some years ago, a pioneer in AI made the comment before a major radiology conference that we should stop training radiologists because we'd all be replaced by AI. He actually walked that back later. But another comment on AI is I encourage everybody who's interested in it to try to learn a little bit about how it works. And that's one of the things I talk about in my AI presentations. Because otherwise it's a black box and you don't know what it's doing. And the whole concept of explainability in AI, how we understand what it's doing to come up with its conclusions, is extremely important, especially in medicine. And there are a couple of related issues. One is if you're a practitioner and you follow what the AI tells you to do, say in risk stratifying a nodule, and there's a bad outcome, who's at fault? And conversely, if the AI says, well, this nodule is such and such, and you do something different, who's at fault? And that has yet to be worked out in an area in medicine or elsewhere. And the last thing I'll mention is that everything I talked about in iTIRADS or any of the other risk stratification systems mostly excludes other techniques like elastography and flow. In the past, flow, as shown on color Doppler, hasn't been terribly helpful, but the newer techniques, which are generally called microflow, which are much more sensitive, I think will be more advantageous in distinguishing benign from malignant nodules. So I think just on the ultrasound side alone, that both sonoelastography and flow will eventually be incorporated.
After we've spoken about AI for a bit, I'm gonna go to the other side of the spectrum. I don't want to go in the bare futuristic and what we should do next. Let's go back to the treatment in the community. And Dr. Kwon, you alluded to this a little bit in your presentation. You said most of the people that have thyroid nodules are treated actually in the community, but not by physicians that are not high volume or not very versed in the language that we're speaking about. So Dr. Tessler, he presented some graphs where we saw how people were using different classification systems. And to my surprise, ATA and TI-RADS are very similarly used, and how often people use one or another. So what do we do with the community physician that is using ATA and can't classify it? What should we advise him? What is the bottom message? Should we tell him this is what you should do? This is A, B, and C of what you should do when you can't classify a nodule? Dr. Tessler, what are your thoughts?
Yeah.
Oh, was that for me or Dr. Kwon?
It's
I'll let you go
either.
first.
Up in the air.
Well, I'd say, like I said before, is look at the nodule again and see if it really is not that far from one of the patterns. And the other is to pull up the ACR TI-RADS chart and see where it fits. That's easy to do. It's widely available. The other thing I'd say is we're November 17th and almost to 2024, and see what the revised ATA guidelines do on this subject, because I know it's top of mind for everybody who's involved in revising those. Like I said before, I don't know specifically what they're doing or how that's going to change, but I suspect there'll be fewer non-classifiable nodules with their 2024 version when it comes out.
Yeah, I mean, I would just say from, my personal experience, things like having these formalized guidelines, something like a kind of a consensus guideline is super important. As you mentioned, it takes a while for some of this to get out into the general community, people who are doing ultrasound. Even just a few years ago, you don't see quite as many categorized nodules in kind of outside radiology community type reports. I would say these days it's fairly rare to even, from small radiology community centers to not see the ACR TI-RADS system being used. And so it does kind of filter through throughout the community, even outside kind of, academic practices. So I think having something that's consistent, if the TI-RADS system became sort of the most widely used system, I think that would be great.
Great. One last question, Dr. Tessler. Do you think all the nodules are classifiable by TI-RADS ACR currently? For example, what do you do with the eggshell macro calcified nodule that you can see its composition, height, direction of growth? What do you do then?
Well, we're as I can't remember if I mentioned this. It may have been before this session started, but we're currently working on revising the ACR TI-RADS, and we'll probably release a revision to it in 2024. And those are some of the things that we're addressing. In order to decide what we're going to work on, we've gathered all the questions we've gotten over the past 6 years, and we're taking the top ones and trying to address those. And I'm doing that in parallel with the TI-RADS effort. So it's going to be an interesting time in the next year or so for me.
Interesting year coming ahead, yes.
Yeah.
Again, I want to thank you both for carving out some time. I want to thank all of the listeners for being here with us this week. Next week, we will not be having a session being that we have Thanksgiving, the holiday next week, but the week after, we're having a session with Dr. Dana Hall from Gustav Morsi and with Dr. Mark Safari with discussion from Dr. Mark Safari on prophylactic unilateral neck dissection and low risk PTC. Thank you again for being here. Thank you, Dr. Tessler. Thank you, Dr. Kwon. Hope to see you soon.
Thank you, and happy Thanksgiving, everybody.
Thank you so much.
Bye.
Bye-bye.